Welcome again. You are watching teleconferencing program. This is the second session of this program. We have with us in our studios as our expert Dr. Sangeeta Sachdeva. The topic of today's second session is basics of echocardiography. If you want to ask any queries about basics of echocardiography, you can make our phone calls in our studios. Our numbers are 29532844, 29532845 and toll free number 1800112345. This program is jointly conducted by Indira Gandhi National Open University and National Board of Examination. If you want to have the DVD of this program, you can contact National Board of Examination. And if you want to download the forms, then you can see the website. The website is www.netboard.edu.in. That is www.netboard.edu.in. I would like to welcome Dr. Sangeeta Sachdeva.
Thank you very much. Well, my topic today is on the basics of echocardiography. Today's lecture I will be covering what are the basic principles of echocardiography, what is the normal heart appearance in echocardiography, and what are the clinical applications in the emergency department, and also the clinical applications when patients come to you generally for echocardiography in the lab. So basically, let's start from the basic. What we need is the equipment, the echo transducer. The frequency of a cardiac transducer is 3.5 to 5 megahertz. It is a phased array of piezoelectric crystals in the transducer. You should have a small footprint because you have to struggle between intercostal spaces, and an index marker available for orientation. An echo equipment is an ultrasound machine which should have these basic, we must have all these things with us now, which is a basic 2D image and a grayscale, M mode, a continuous wave Doppler, pulse wave Doppler, color form mapping / imaging, a cine loop mode to allow frame to frame assessment, and a cardiac package for calculation that is optional for an emergency or a portable echo, but otherwise in a lab you must have all these these parameters with you in the machine. To start, you must undress the top of the patient, make him lie in the supine position, turn him slightly left lateral for a better echo image, and if you are taking a subcostal view, I will be discussing the views later on. You must hyperextend, you must make him bend the knee, while for suprasternal views, you must hyperextend the neck. Adequately apply sonic gel on the transducer, and you must put a 3D ECG monitor. You may get poor echo images in patients with morbid obesity, those who have COAD, hyperinflated chest, and those with chest wall deformities. So what is the orientation of an echo image? Once you put the probe on, based on the standards recommended by the American Society of Echocardiography, the image index marker should appear on the right side of the image display. And in contrast to the conventional abdominal ultrasound, where there is a left side orientation, the circled area is where the marker is. You can see it here. Acoustic windows, in order for the ultrasound beam to reach the heart without being obstructed by ribs, we have there has been postulated there are certain several orthodox windows which are commonly used. You just don't put the probe anywhere in the chest. Those are the parasternal window, they are called apical window, subcostal window, a suprasternal window, and a right parasternal window, which is used for certain cases, like in cases of aortic stenosis, to calculate the gradient when you are not getting it properly on the other side. So in this view you can see the heart as it's lying in the chest cavity. The one on the top is suprasternal. Parasternal is between the second and third intercostal space on the left side. Apical is where the apex is on the fifth intercostal space. And subcostal is near the xiphisternum, where you put it between and try to see the heart from below. Along with the views, you have certain echo planes which we cut across. Now you are seeing in this view, there are the three important planes, imaging planes. When we put the transducer, we put in the window, and then we see them in these three planes. One is the long axis view, the short axis view, and the four chamber plane. Now in the echo views, these are the different views, and you can see how in the parasternal you have the long axis view on the top. You can see all the three apical, parasternal, and suprasternal, how you see the long axis in different windows. In the apical views, you can see how you see the 4-chamber, you can see a 5-chamber view and a long axis view. While in subcostal views, you can get the long axis and short axis. While in suprasternal also, you can get long axis and short axis views. Now the probe position, here you can see the probe position is put in the long axis, the index marker, the transducer should be pointing to the right shoulders. Same transducer, when you turn the marker pointing to the left shoulder to about 90 degrees, you will be able to see the short axis view. And this is the cut section where you see the short axis, where you are seeing the LV and the RV in the bottom picture. This is how a conventional parasternal long axis view looks like, This is how it is in the heart, and this is how it looks in the echo. So you can see the LV, the RV, the subvalvular apparatus, the LA, the aorta, everything can be visualized in this, and this is the same way it is seen in the echocardiography itself. This is a very important view also. Now by tilting and shifting, once you turn it by 90 degrees and you tilt and shift along the line of the long axis, you get series of plane from apex to pulmonary artery. So when you tilt initially, you will get from the pulmonary artery level, then you get at the aortic level, the mitral level, then the papillary muscle level and the apex level, and through these different levels you can evaluate the heart at the different valvular levels, and also you can see the different wall motion also. This is the parasternal short axis view at the level of the papillary muscle. You can see the left ventricle and the right ventricle as a cut section on the short axis, and you can see the two papillary muscles also in the left ventricle. The picture can be seen as it's seen in a cut section of a heart, and below you can see it as we see it on the echocardiography. Then as you tilt at the aortic valve level, you can see the three cusps of the aortic wall, the right coronary cusp on the top, left on the left side, and non-coronary cell on the other side. And here you can see the right ventricle, the left atrium, and the RVOT. So you can see the RVOT which is opening in, you can see the pulmonary valve and the aortic valve here. And this is a very important view in children when we do for transposition, because you will not, in transposition of aorta, you will not get the conventional parasternal short axis view. You will get two circles instead of this view. The two valves will be looking like two circles, the pulmonary and the aortic. This is the apical view. As I had mentioned, you put it at the apex, you will get you will see the 4-chamber view in this and a 2-chamber view. In the 4-chamber view, you get the LV, RV, RA and LA, while you tilt it and you will get a 2-chamber view, which I will be discussing in the next slide. In the 4-chamber view, you palpate the apex beat, place the transducer at the apex towards the patient's head. Index mark is rotated to approximately 3 o'clock position. And for the 5-chamber view, you have to fan the transducer at the apex so that you open up the LVOT and the aortic valve, which is the 5th chamber. For a long axis view, you rotate the transducer 90 degrees anti-clockwise with the index marker pointing to the suprasternal notch, and 2-chamber you rotate the transducer 45 degrees clockwise from the long axis view. It may sound a little complicated when I am telling you all these 3 o'clock, 9 and 45 degrees clockwise, but when you have a patient in front of you with the probe in the hand, it is very, very easy and really becomes very easy to follow and almost mechanical after some time. This is the apical 4-chamber view. You are seeing the LV, the RV, the LA and the RA. You can see the papillary muscles, you can see the mitral valve, the tricuspid valve and the apex of the heart. The septum is on the left side and the right side is the lateral wall of the LV. When you do the 2-chamber view, which I had mentioned before, then you get the inferior wall on the left side. So you can see if there is any inferior wall hypokinesis or akinesis, while there you can see septum here you can see the septum. So you can see the wall motion abnormalities of the left ventricle through this. In the subcostal, you place the transducer below the xiphoid process. The index marker is rotated to about 3 o'clock position. For short axis, you rotate the transducer by 90 degrees anti-clockwise so that the index marker is pointed at 12 o'clock position. And from this views, you will be able to see this is the subcostal long axis view, in which you are able to see all the 4 chambers of the heart. You see the interventricular septum, the tricuspid valve and the mitral valve. And the subcostal short axis is similar to the parasternal long axis view. If you tilt posteriorly, you can below, you will be also seeing the IVC, and you will be able to assess the size of the IVC and inspiratory variation in size so that you can calculate the pressures on the right side. The dynamic assessment on echo you have 2D image, you have the anatomical assessment, valvular movements, and the regional wall motion is analysis is done. With M mode, you do the motion assessment over time, distance or depth measurements. Then you have the continuous wave and the pulse Doppler. You do the hemodynamic assessment with them. You calculate the velocities and the pressure gradients. And then you have color flow mapping, which is for both hemodynamic and anatomical information. So you see, you get a patient, you see the parasternal long axis view, you do the parasternal short axis at different levels, aortic level, valve level, papillary muscle level, right till the apex, do the apical 4-chamber view, and where required you do the suprasternal and subcostal views. So when does a patient come to you? Why does a patient come to you in the echo lab? There are many indications. They can come for many causes. A person has a murmur, he will be sent for echo. Patients for valvular heart disease, native valvular stenosis, native valvular regurgitations, for patients with repeated study in valvular heart disease, for mitral valve prolapse, for patients with infective endocarditis on native valves, prosthetic valve dysfunction and endocarditis. Then patients coming with chest pain, those with ischemic heart disease. You have to find out is it a ischemic pain, is it a atypical chest pain. You do an echo. For patients in ischemic heart disease, for acute ischemic syndromes, for chronic ischemic heart disease. Then for cardiomyopathies, an assessment of left ventricular function. A patient is sent to you, patient is in shock. We want to see if his ejection fraction is all right. Patients with edema and breathlessness, they send you for echocardiography. Patients of dilated cardiomyopathy, known patients, they come for you for follow-up. Hypertrophic cardiomyopathy, restrictive cardiomyopathy, patients with heart failure with normal systolic functions, for the evaluation of the right ventricle. Then those patients with pericardial diseases, you have patients with effusion, whether the patient has cardiac tamponade or not, how much is the effusion, whether there is pericardial thickness, whether there is constrictive pericarditis, for those patients for pericardial tumors and cysts. Then those with congenital absence of pericardium and pericardial disease after open heart surgery. There are patients with cardiac masses and tumors. Then diseases of great vessels, aortic dissection, aortic aneurysm, aortic rupture, thoracic aortic degenerative diseases, and the great vein diseases. Pulmonary disease, systemic hypertension, neurological diseases and other cardioembolic diseases. You have to see whether the patient has any cardiac problem or not. Those patients are sent to you. And for arrhythmias and palpitations. For cardioversion of patients with AF, it's very necessary to see whether there is an LA clot or not, or in the appendage, and those patients come to you for transthoracic and later on even transesophageal echo. Patients of syncope, you have to find the cause, any cardiac cause of syncope, those patients come to you for echo. And then screening, and even for patients who are screening for insurance purposes, patients who are going for surgery, those patients have to be cleared for surgery. For cardiac fitness, they come to you for echo. And echocardiography in the critically ill, which I will be discussing on portable echoes, and echocardiography in the trauma patient. Then you have adult patients with congenital heart disease, and echocardiography in pediatric patients, neonates with arrhythmias, neonates with cardiopulmonary disease, with myocardial disease in the neonates, and the same in infants, child and adolescents, and those with thrombus or tumor. We also do transesophageal echocardiographies and fetal echocardiography. So you see there is vast indications. Echocardiography, you think of a cause and those patients can come to you for echocardiography. It's a very, very useful modality, and it can help you in the management of the patient and in the diagnosis of the patient. Coming to emergency echocardiography, it was first employed in the emergency department in 1980s in USA. It allows a rapid recognition of life-threatening conditions and direct appropriate intervention and treatment. It's mainly a focused examination. You have to get, it's a critical situation. You have to try to answer clinical questions. And in most situations, you may only require a quick 2D scan, and Doppler may help. When the patient is very sick, you don't have time to do a full study. You can only do a 2D scan. Primary indications, just in short, like you can discuss, it is useful in patients of pericardial effusion, whether they got cardiac tamponade or not, evaluation of cardiac activity in cardiac arrest patients, in left ventricular systolic function evaluation, and extended indications is in the estimation of intravascular volume status. Very often in the intensive care unit you get such echoes. RV evaluation of the proximal aorta for dissection or aneurysm, and for procedural guidance. It can help in patients of trauma, cardiac arrest, unexplained hypertension, patients with shortness of breath, chest pain, and for procedural guidance for pericardiocentesis. Trauma is a part of the FAST scan today in ATLS. It is mainly detecting pericardial effusion and tamponade, prognostic benefit for penetrating chest injury patients, and an urgent pericardiocentesis is required for patients if they have tamponade. How do you detect pericardial effusion? Normally there is an echo-free rim around the heart within the hyperechoic parietal pericardium. Maybe complex echogenic. If fluid accumulation is due to inflammation and malignancy, it may not be echo-free completely, because pus or any other fluid, any other inflammation or malignancy can cause it to become more echo-dense. False positive, you can have an epicardial pad of fat which is present, but it is normally not echolucent, and you have pleural effusion, may be confused with pericardial effusion, but there are certain differential points which we can discuss in a later lecture. In a subcostal view, here you can see the rim which is surrounding the short axis view of the left ventricle, and you can see that echoluscent rim which is surrounding it. A pericardial effusion, when you see it, how do you call it? A small effusion, a large effusion, or a moderate effusion, or a very large effusion? So if it is less than 10 millimeter in diastole and is only posteriorly and not circumferential, it is called small. Equal to or less than 10 millimeter but it is circumferential, it becomes moderate, and large is about 10 to 20 millimeter with and it is circumferential, and very large is more than 20, which is circumferential with or without features of tamponade. Pericardial effusion causing hemodynamic collapse because of impaired ventricular filling and in turn cardiac output is seen in tamponade. There is an acute accumulation of even small amount of fluid in a pericardial sac can have significant hemodynamic effect due to the rigid fibrous sac. There is a Beck's triad of cardiac tamponade where you get elevated JVP, muffled heart sounds, and hypotension. So the echo features of cardiac tamponade, patient comes to you with pericardial effusion. Does he or she have tamponade? You have to see for RV diastolic collapse. I will be showing you later on. RV wall, free wall moves towards the RV cavity early in diastole. Normally it is moving away. Here it moves towards, and RA moves inwards at the end of diastole and the beginning of systole. Here you can see the RA free wall invagination during diastole in a patient of cardiac tamponade. Here before and after pericardiocentesis, you can see that there was a right atrial collapse which is after success of procedure. It is not seen in the second slide. In patients of cardiac arrest, this mainly detects organized cardiac activity. You have to find treatable causes of pulseless cardiac activity, electrical activity, like a cardiac tamponade, hypovolemia, or a massive pulmonary embolism. In patients of unexplained hypotension, you obtain a subcostal or a parasternal long axis view, assess for a pericardial effusion or tamponade, then you assess for wall motion abnormalities. If it is a hypocontractile large LV segment, there is a primary left ventricular failure, so you give inotropic support. But if there is RV hypokinesis with a normal LV, then there may be a RV infarction or a massive pulmonary embolism. You have to give fluid resuscitation. So with echo, you can decide what clinical treatment you have to give to the patient. Hypovolemia, what do you see in the echo? There will be a small heart with a near complete systolic emptying and a flat IVC with exaggerated normal respiratory variation. You must assess the abdominal for abdominal aortic aneurysm and hemoperitoneum in such cases. For the left ventricular systolic function evaluation is useful again in hypotensive patients to differentiate a cardiogenic or a non-cardiogenic shock. Left ventricular systolic function can be accurately assessed by the EP in hypotensive patients. To assess the systolic functional evaluation, you do a 2D echo by the Simpson methods, apical 2-chamber or 4-chamber view. It divides the LV into different slices of known thickness, and you know the volume size is equal to slice area into slice thickness. By this you calculate the ejection fraction. You take the ejection, the end diastolic volume and systolic volume, and this is the formula which I think everyone knows. The left ventricular end diastolic volume minus the left ventricular end systolic volume divided by the left ventricular end diastolic volume into 100% gives you the ejection fraction. Of course, our echo machines now calculated once you feed the diastolic volumes and systolic volumes, and you normally don't need to calculate it on yourself or by yourself. The normal ejection fraction is 50 to 70%. To assess the preload in a patient you normally see a IVC which collapses with inspiration. In a hypovolemia, it will be absolutely a collapsed IVC. While in right ventricular failure, in right ventricular MI, in massive pulmonary embolism, in TR, in cardiac tamponade, you have a distended IVC and a loss of inspiratory collapse. With seeing the IVC, you can even do a semi-quantitative estimation of the right atrial pressures. This is a slide which shows you a rough idea. You see the IV size and the change with inspiration. In patients of hypovolemia, the size will be less than 1.5 centimeter and the change with inspiration will be it completely collapses. Estimated RA pressure 0 to 5. With normal 1 to 5 to 1.5 to 2.5, it decreases more than 50% with inspiration. Estimated right atrial pressures will be 5 to 10. In patients with dilated IVC size is more than 2.5 and the change with inspiration decreases less than 50%. Estimated right atrial pressures are 15 to 20. And when it is very dilated, more than 2.5 plus distended hepatic veins and no change with inspiration, the estimated right atrial pressures are more than 20. Coming to chest pain, a patient comes to you with chest pain. What is the detectable causes by echo? You can get an acute myocardial infarction, acute coronary syndrome. You will get a regional wall motion abnormality. While in dissection, you will get a dilated aorta and a visible intimal flap. In pulmonary embolism, you'll get a dilated RA, RV and IVC. A visible thrombus may be seen in the RV and RA. And with pericarditis with effusion, you'll see pericardial effusion obviously. In patients of dissection, an intimal tear is seen in the aorta, causing the blood tracking through the aortic media, creating complications. There are different classifications as per how far the tear goes and from where it starts and where does it end. What is the sensitivity of aortic dissection? Transthoracic aorta is only 70% and is mainly for nearly 100%. The features on transthoracic echo, mainly for proximal aortic dissection, you will be able to see the intimal flap and a dilated aorta and AR will be present. You may also have pericardial effusion. Here you can see the intimal flap at the LVOT. This is a patient of aortic dissection with AR. Severe AR is seen in this patient. Now, going further on, as we are talking so much about emergency, we have a portable machine now. We have very good portable machines which are handheld devices with excellent image quality, and these comprise approximately 10 to 20% of the total work done in the non-invasive cardiac lab. So what is the use? Emergency echocardiography gives you a rapid, non-invasive information. It gives you value in decision making in cardiovascular emergencies and critically ill, and the results are immediately available. What are the clinical situations where you will be needing to do an emergency echo? It could be severe pain chest, breathlessness, hypotension, tachycardia, desaturation, generalized anasarca, fever, patient very toxic, ECG changes specific or non-specific, patients of paralysis, neurological symptoms to see for any cardiac source, and for preoperative assessment. That sometimes becomes an emergency also because the patient has to be operated immediately. So what are the uses of emergency echocardiography? As we have already touched on certain topics, I can just sum it up as acute coronary syndrome, complications of acute MI, cardiac tamponade, acute prosthetic heart valve disease, acute diseases of heart vessels, chest trauma, cardiac arrest, dyspnea, desaturation and iatrogenic complications. Emergency echocardiography, as I have already mentioned, this is the same slide. For patients of non-cardiac chest pain it could be a psychological, myalgia, aortic dissection, pulmonary embolism, pneumothorax or esophageal rupture. While in cases of acute coronary syndrome, its potential use is based on the effects of interruption of coronary flow. LV diastolic dysfunction may occur before systolic function, and you must remember that ECG abnormalities and chest pain are relatively late events, and it detects systolic wall motion and thickening abnormalities in case of suspected MI. Here this is a case of patient who comes to you. There is a ruptured cordy. The patient came suddenly with to you for some MR, and there was he was in a very bad state. You do an echo and you see there is a ruptured cordy. This is a patient who came with severe chest pain. ECG changes, echo done, shows you LAD area hypokinesis in this patient. This is a patient who has a pseudoaneurysm. Pseudoaneurysm is that when there is a rupture and the myocardium doesn't form the wall of the aneurysm, it is the pericardium itself which is forming the wall. When you differentiate it from a true aneurysm, in this patient the lateral wall there is a rupture of the lateral wall, and you can see that there is a aneurysm of the which is actually lined by the myocardium itself. What are the you can even in echo you can see the mechanical complications of MI like cardiac rupture, which I've shown you just now. You can see a VSD which occurs at the site at the junction of infarcted and hyperkinetic area, and you can see acute MR due to rupture of papillary muscle. Here this is rupture of papillary muscle, which is can be the arrows can show you that the papillary muscle has ruptured, and this is a mitral valve below. This is a patient of who has a VSD at the basal septum, and you can see on the color you can see the flow through the ruptured site. There is another patient where there is a rupture of the inferior wall. In cases of cardiac tamponade, patient has dyspnea, tachycardia and tachypnea, will have engorged neck pains and pulsus paradoxicus. Here is what I was talking about, RV diastolic collapse. You can see that in diastole the RV diastolic collapse is occurring. Normally it should not go down in the diastole. This is again a patient of tamponade, mitral valve open, aortic valve closed, and there is invagination of the RV. That the arrow below you can see, that is called RV diastolic collapse. In blunt chest trauma, patients can come with tamponade and effusion, as I have already discussed. You can also have wall motion abnormalities like cardiac rupture can take place. RV takes the first hit in these patients. Acute MR due to valvular disruption, aortic dissection and structural abnormalities. This is a patient with blunt trauma who had come to us. You can see the large effusion in this patient. This is another patient with high grade fever. He has fibrous strands, there is a pericardial effusion as you can see, and thick fibrous strands around, which turned out to be tubercular. In patients of aortic dissection, I have already mentioned transthoracic has lower sensitivity, transesophageal has greater sensitivity and specificity, and T detects extent, communication points and severity of AR. Now this is a patient with aortic dissection. You can see a dilated aortic root. You are not able to see the flap very well, but here when you do a transesophageal, you can see the dissection as well as you can see the AR here, and you can see the flap of the dissection. Patients of pulmonary embolism in echo, you can see sometimes see the thrombus in pulmonary artery. You have to see the TR, RV dysfunction and RV wall motion abnormalities. Here this is a patient of pulmonary embolism, very nicely a transesophageal echo. You can see the thrombus which is sitting in the pulmonary artery on the top. Acute native and prosthetic valve disease, patients can come to you, have to see for infective endocarditis, you have to see for acute aortic or mitral regurgitations, prosthetic heart valve thrombosis, ring abscess, paravalvular regurgitations and dehiscence of prosthetic heart valve. Here there is a patient, you can see a mitral prosthetic heart valve, and you can see that the patient has, here you can see the thrombus which is on the valve. This is a paravalvular MR which you can see. This is a prosthetic valve, and this patient also of course has a TR, but you can see a paravalvular MR. Here you can see a vegetation on the mitral valve which is going in and out, a very long vegetation. Patient had prolonged history of fever, blood cultures were positive and responded to treatment, and this vegetation is the one which was picked up in the echocardiography. Here there is a aortic valve regurgitation. You can see this patient has aortic valve regurgitation. In patients of hypertension and shock, as we discussed in cardiac, in MI there will be a poor LV contractility. In patients with tamponade is another cardiac cause of hypertension and shock. Patients with cardiomyopathy with acute regurgitation and RV infarcts, while non-cardiac causes are hypovolemia, sepsis, anaphylactic shock and ruptured aortic aneurysm. This is a patient of dilated cardiomyopathy, came in hypertension with shock, dilated LV with reduced contractility. This is a patient, you can see the dilated RV and RA, severe pH as calculated by the TR jet, and there was RV dysfunction in this patient. This is a patient who's got, this is due to hypovolemia. You can see a small LV and a small LA, and there is a normal function which was present in this patient, but you can see the difference, the LV and LA are so small. Intracardiac thrombi are also picked up in echo. They can be post MI or in those in cardiomyopathy. Here there is a patient, you can see this large thrombus seen at the LV apex. This is another patient with LV thrombus. Here you can see highly mobile, very dangerous. This can break away any time. This is a big thrombus on the LV apex of